Hello, everybody, and welcome to the IOCDS Research Roundtable, the IOCDF stream where we pick an interesting and developing topic within the OCD literature and discuss it with the folks that know it best. My name is Kyle King. I'm an incoming medical student now at the Yale School of Medicine, and I've been doing research in OCD for 4 years throughout undergrad, and I look forward to doing it in the future. Not only because I think OCD is really interesting and there's a lot of interesting things to think and talk about, but also because I have OCD. So a lot of the stuff that we talk about on this show is personal and means a lot to me. This month, unlike last month, unfortunately, I'm joined by my co-host, John Abramowitz. John, if you want to say a word or two about yourself.
Thanks. I'm back. Sorry.
Yeah, don't worry about it.
That's a good thing. A word about myself. I'm a professor at the University of North Carolina, and I study all different areas of OCD and do treatment with folks who have OCD. And just think this is like Kyle. It's a fascinating disorder. I don't personally have OCD, but I'm fascinated by folks who have and enjoy learning from them. And today, we're going to have a lot of fun because we have an awesome group of guests and a really cool topic that's near and dear to my heart. Some of the research that I've been working on most recently has to do with perinatal OCD.
Yeah, I was poking around Google Scholar before the show, and I was reading up a little bit about it, and I was just disappointed that I can't get away from John's name. It's so frustrating. But yes, we're going to be talking about perinatal OCD. Sometimes in this part, I'll offer up a definition just generally of what the topic is, but I'm going to let the guests do it when I start introducing them. But I am really excited to talk about perinatal OCD specifically because I was just on a trip with my family. We went to Argentina on family vacation, and my sister has a 1.5-year-old, and I'd been told that raising a kid is a lot of work. And it was not until I got to see her and her husband doing the act of raising a kid that I realized that it's a lot of work. So I'm excited to learn more just kind of about everything related to this subject. Before I go about introducing our guests, I do have to say a few more words. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find help to locate a trained clinician near you. Also, the International OCD Foundation is not a crisis hotline. If you are in crisis or if you're ever feeling suicidal or unsafe, please call the 988 Suicide and Crisis Lifeline by dialing 988. You can also access this online at www.988lifeline.org or go to your local emergency room or call 911. Also, like I say every month, this is a totally live stream. You can, as the name live stream implies, you can say anything in the comment section. You can type questions or say John, great point, or John, bad point, whatever. But just be respectful. I guess that kind of contradicted the joke I just made. But be respectful. Just remember everything that you say in the comment section will live on in the internet forever. So just be mindful of that, though we've never had any particular troubles. Okay. I think that's all that I need to say. Now it's time to introduce the people who will be educating, at least me. I'll start with our panelist, Mary Kimmel. Mary Kimmel received her MD degree from Drexel University in Philadelphia and her PhD from Uppsala University in Sweden. Dr. Kimmel is an associate professor in psychiatry at the Washington University in St. Louis. Her clinical work focuses on the mental health care of pregnant and postpartum people, particularly those with high-risk pregnancies and more complex medical needs. In recent years, she was the medical director for the NC Matters program at the state of North Carolina, providing education and consultation about mental health, including perinatal OCD, to all providers working with pregnant or postpartum people. She currently is focusing on researching biomarkers of the microbiota, gut-brain axis, and the autonomic nervous system to improve identification and treatment of perinatal stress and perinatal mood and anxiety disorders, including perinatal OCD. So certainly a good person to have on the stream today. Mary, I have a tradition of asking not just how you're doing, and because I just got back from vacation, where is the next place on your bucket list if you had to go somewhere else outside of the U.S.?
Wow. So I'm going to go with where I just went. So I was at a working group meeting with the European Union. They have a cost action looking at maternal biomarkers of maternal stress, and infant outcomes. And that was in Cork, Ireland. And so while I was in Cork, a colleague there referred me to go down to Kinsale, and it's on the coast, and it was beautiful. And I learned a lot of Irish history, and I had a really good seafood lunch. So, yeah.
Okay. That sounds lovely. Is Cork, Ireland, where cork, like for wine bottles, comes from?
No, that actually I think comes from, they like have cork in, I think in another part of Europe where that really comes from. Yeah. I don't know why it's called cork. I don't know.
It might have been a stupid question, but I felt the need to ask.
It's a very good question. I'm curious. Why is it called cork? I don't know. I'll have to look up.
If only there was a device that could help us figure that
out. You get on the trail of researching that. I'll introduce our next guest, Melissa Mulcahy. Melissa Mulcahy is a clinical psychologist based in Perth, Western Australia. Thank you for joining from Australia, where she works with OCD and related disorders, including in the perinatal period. Her research, conducted at Curtin University during her PhD, focused on factors predicting postpartum OCD symptoms and approaches to prevention and treatment. Melissa remains involved in research in this area as a member of the IOCDS Perinatal Task Force Research Subcommittee. Again, a great person to have on the stream today. Melissa, same question goes out to you. Where is the next place you would like to visit?
Oh, you know what? That's a pretty easy one for me to answer, I think. So as of next week, I'm headed over to the States. I'm going to have a bit of a holiday in Florida before picking up OCD conference and come back via New York. So I've never been to the States before, and I'm really excited.
I didn't know that.
Okay.
Yeah.
As a native Floridian, I'm so excited for you. Also, we just got a private chat that Portugal is the world's largest cork producer.
That's what I thought, but I didn't want to be wrong.
That's from. We should give a shout out to Boris, who is our awesome producer behind the scenes. No one, we can't see him if you're out in YouTube land, or Facebook land, but behind the scenes, he's the one who's making this all happen. So thanks, Boris.
Yeah, thank you, Boris. Our final guest is Fiona Challacombe. She's a clinical psychologist and researcher in the field of perinatal mental health. She is currently a clinical lecturer in perinatal psychology at King's College London and works in a national specialist NHS clinical service for people with anxiety disorders, primarily working with perinatal clients. Fiona conducted her first randomized trial of psychological therapy for perinatal OCD and has recently completed a trial of intensive CBT for pregnant women with anxiety disorders, including perinatal OCD. She is the patron of the service user-led charity, Maternal OCD, which raises awareness for the disorder amongst service users and healthcare providers. Alongside Maternal OCD, she has co-produced training materials and accessible information on perinatal OCD. She is the co-author of Break Free from Maternal Anxiety, a self-help and practitioner book, and self-help and practitioner books on the treatment of OCD. Fiona, I read the papers you sent along in our email thread, and it led to a whole new line of questioning in this document where I keep all my questions, because they opened up a Pandora's box, which I'll get into later, I guess. But the question goes out to you. Where's the next place you'd like to visit?
Thanks so much for having me here. At the moment, because it's been in traditional British way raining for about the last 3 months, anywhere but here really that's got any sort of temperature is our usual desire. But unfortunately, I've only got a holiday in the UK planned, so hopefully the clouds will open. I've always wanted to go to Iceland, though. That's still on the bucket list.
Okay, interesting. That's where my mom, I think, wants to go on her next family vacation. Also, I said Challacombe as a reference to some jokes you're making off screen. I was just wanted to make sure that I didn't pronounce your name wrong on the stream, and then I decided, so if it's Challacombe, I'm sorry.
Challacombe is okay, but that's a reasonable attempt compared with some. So
thank you. I try to be reasonable, not perfect, but reasonable. Okay. So let's get into the meat of things here. Nathan asked a question that I didn't want to approach out of fear that I may get it wrong. What is perinatal OCD? What's the definition? That's for anybody.
Well, I can start with what is perinatal.
Okay.
So we'll break it down.
Yeah.
So we often, and there's actually often kind of even a back and forth debate about which term to use. And so perinatal, most of us tend to think of that including the time around birth, right? And so that really includes, and we take a really long period from pregnancy to, and some would even say, preconception, pregnancy to birth, to delivery, to the postpartum period. And then how you define the postpartum period is also debated. Some people would say, the DSM diagnostic manual for psychiatry says that they have a qualifier for depression that puts it at pregnancy and within 4 weeks of delivery. But most of us say really up to a year. And actually to, thinking about your sister, they're like when you up to having, it's really even through breastfeeding, it can be through, it's kind of even, but really until they get support where the kids are sort of, toddlerhood and in preschool. And so it depends on how you define that, but that's kind of about where we're defining it is pregnancy and postpartum.
Okay. And postpartum specifically is itself a little unclear.
Yes.
Melissa and Fiona, do you have anything you might want to add to that definition?
Yeah, I think Mary's absolutely right. The definitions kind of have differed in the terms. So previously the term postnatal when prenatal was used, antenatal to refer to kind of pregnancy, postnatal, same as postpartum. But when we're talking about OCD, we're usually speaking about the experience of OCD in that perinatal period. And often, most of the time, we're referring to perhaps a worsening of symptoms in that time, or for some individuals, maybe the onset or re-emergence of symptoms for the first time, or a new episode of OCD.
Yeah,
that
was my next question. Oh, sorry, Fiona, you go.
And I was going to say that's a really important observation, I think, and I like the way also, Mary, you mentioned the sort of even the preconception. So we have, women in the clinic who are thinking about conceiving, who are very concerned about the impact. And here the convention is we go up to kind of 1 year, but there's definitely an acknowledgement that actually as your child is gaining kind of autonomy, there are particular issues that can kind of be challenging for folks. So.
And I would just add, I think the other interesting question is perinatal OCD separate from OCD at other times? And I think it probably depends on the individual, but is there a subset that is unique to the perinatal period? And is there then kind of OCD that is in the perinatal period?
Yeah. How would you go even about parsing out a question like that?
Research?
All right. I guess we can get into the specifics of that later. So Melissa, you mentioned that like perinatal OCD, it could refer to the worsening of symptoms or the onset or reemergence of symptoms. Is there kind of like a general, like when we're talking about perinatal OCD, is one more common? Is it typically a worsening? And then there's a smaller subset of women who experience kind of a totally new onset? Or is it totally new onset typically? What's kind of the split?
I think it's a bit of a combination. So I'm not quite sure on the specific figures, but it's common to see individuals who they are experiencing OCD for the first time. Perhaps there were some symptoms that were kind of evident kind of earlier in their life, but kind of never really got to a point where they needed to seek support for that. But then there was kind of the perinatal period hit, and there was a real exacerbation that happened. So we know that it absolutely is associated with people maybe experiencing OCD for the first time. At the same time, we know that in the perinatal period, there is just an increase in symptoms, OCD symptoms generally. So there's an increase in obsessive compulsive symptoms in the general population, where they're not kind of meeting full criteria for OCD, but there's a high proportion of the population that are experiencing some OCD symptoms, and a higher and an exacerbation for people who maybe already have OCD as well.
So there's just kind of like a general spike in
Mm.
these sorts of thoughts. How do you parse out like a worry? Like I know my sister's husband asked the doctor after the baby was delivered, how do I make sure that the baby is still breathing? Which like very easily could be construed as a thought that you could have with OCD. So how do you parse out kind of like a typical worry of being a new parent or you know, carrying a pregnancy from something like OCD?
I think it's a really common question and a really good question. And I guess the answer is we don't have there's no strict line in terms of kind of content or how many thoughts or anything like that. And I think, you know, as with our normal clinical assessments, everything is on a spectrum. So I think it's the extent to which those thoughts are occurring, the extent to which behaviors are then occurring as a result of them, and how they might start to interfere with what the person's doing. Is reassuring is always kind of quite a good guide as to whether this is starting to become a problem. Are people getting stuck in cycles? But yeah, they're very typical concerns of any new parent. So it can be really difficult to recognize that things are becoming a problem for many people.
And just like in the non, you know, perinatal diagnosis of you know, mental disorders, psychiatric disorders, it's not kind of like what you were saying, Fiona. It's not the boundaries are not perfect. It's not black and white, and there could be lots of debate about, is this generalized anxiety disorder? Is it OCD? And of course, you see the same thing in the perinatal period as well.
Mm-hmm. And okay. Yeah, it never seems to be a particularly black and white answer that I get on this show. Is it something that? Well, actually, let me back up and ask a different question. Are the obsessions in perinatal OCD, when we talk about it, are they always about the child and child rearing, or can it just be an exacerbation of totally separate OCD symptoms?
Again, I mean, I would say typically, very often, I mean, OCD is usually about the thing that's kind of going on in front of you. That's typical, but there's a very interesting group of people for whom they're absolutely fine with the caregiving, but the OCD about whatever else it is troubling them. So all things are possible.
Okay.
Just to add to that, there is a systematic review and meta-analysis that I think Starcevic and a couple of colleagues did a few years ago, and they kind of looked at kind of the prevalence of different OCD symptom dimensions in non-perinatal women, in pregnant women, and in the postpartum period as well. And there were some differences that were kind of found in terms of harm-related obsessions, and of course infant-related obsessions were more common in the postpartum sample, and contamination concerns were less common. So it seems to be a bit of a mix between OCD can kind of present obsessions and intrusions can be about anything, and compulsions can be whatever does reduce anxiety for that person. But there does seem to be an increased prevalence of certain types of symptoms in the postpartum in particular. That's based on kind of, just a small number of studies at this point.
I think OCD is quite good at saying, at this time, what would be the worst possible thing you could have in your mind? So I think in my clinical experience, you know, sexual obsessions and thoughts of deliberate harm in that way are the very common for perinatal people, and those are very distressing and troubling, often misinterpreted, and have all sorts of difficulties in terms of help seeking. But I've noticed that is a particularly common presentation in the perinatal period.
Not just for the moms who are the childbearing moms, by the way. Partners experience this as well. Maybe we can talk about that later on too.
Yeah, I was going to ask, you know, is this something that is not just the birth giving person, but also someone else they experience these sorts of symptoms? Are there any other kind of like particularly common obsessions though, while we're talking about it, just to air them out if any of our viewers are experiencing them?
I think, you know, some of the ones that we see very commonly are things like, what if I drop the baby? But then it can also morph into even sort of visual images. And people who tend to be more sort of visual people may have really graphic images of being at the top of the stairs and the baby flying through the air and landing. So it can kind of go from dropping the baby to kind of these visual, like very graphic kinds of things. The kind of what's in front of you to that is it's like you're in the always an interesting one that actually I've had multiple people have is like, what if about the microwave? What if I put the baby in the microwave? It's like, oh, the baby's the size of the microwave. I think it is kind of one of those things that's just like, oh, the baby is the size of the microwave. And then it's like, that's a weird thought. Why am I having, that's a horrible, like, and then you start to go down this road of like, oh, that's a horrible thought. Why would a mother have that kind of thought? Why would a parent have that kind of thought? So I think they often are kind of, and to Fiona's point, definitely like kind of the thoughts about worry about abuse and kind of these kind of worst case scenarios. But also I think it can depend on the situation. I saw in the chat that someone was asking about traumatic birthing experience. And I've been very interested in that because we've seen, we have a specialized unit for individuals who are pregnant and postpartum people who need higher level of care, psychiatric care. And it struck me that I would often see patients who'd had kind of traumatic births, who'd had, maybe preeclampsia, emergency C-section, these kinds of things. And then kind of that over time developed into it. And so, or had a baby in the NICU. And so like the contamination thing, if you have a baby in the NICU and people are constantly telling you, like, if your baby gets an infection, the baby's gonna have to get this like spinal tap and all these things, and your baby's really highly at risk. And you've already been through seeing your baby be at risk and possibly losing your baby, then those things kind of, so for that person, it may be more of that kind of intrusive thoughts about contamination,
Yeah.
And, so.
SIDS, also sudden infant death syndrome. What if my kid stops breathing in the middle of the night? I think someone mentioned that before. And we see folks that like they're checking all the time, and they set up all sorts of elaborate monitoring devices and things like that. And
all the sorts of games that OCD is really good at playing.
Yeah. Oh, absolutely. We're doing a study now looking at the use of like smartphone technology by new parents to check on their babies. And
the research question being what exactly?
We think that there's a relationship between folks that have higher OCD and more kind of beliefs about like increased likelihood of danger and things like that, and that's going to predict more use of, there are all sorts of cameras and apps and things like that folks use now that weren't around. I mean, my parents had a death wish, right? No one had cameras checking on me in 1970.
Is there, Mary, you kind of like just right from the jump expanded my definition of like what exactly we were going to be talking about to include like maybe some of the preconception period and then all of pregnancy. Is there like a different relative risks as you move through? Like at 3 months of pregnancy, is your risk of kind of having this sudden onset different than at 6 months, than at 9 months, than at a year after? Melissa is smiling.
Yeah, smiling because I believe Fiona was an author on a paper as well that kind of looked at that and kind of weighted prevalence across different points in the perinatal period. And so she might be able to speak to that a little bit more clearly. But that was a wonderful study.
I want to hear about it.
Well, this is Nicole Fairbrother's fantastic work. So she did diagnostic interviews with a whole group of mums and birthing people as they kind of went through the perinatal period. And in that was very careful also to ask about child-related obsessions and compulsions too. So to really, because lots of things like we've been discussing, people wouldn't necessarily consider that as an obsession or compulsion. So very high prevalence found sort of across the piece, but in terms of the kind of this particularly postnatal prevalence and that 3 month time, which is actually quite consistent with a lot of studies in the perinatal period. And I think for many parents could sort of relate to the fact that you sort of run out of gas at that point, and you've run out of cake, and people have stopped visiting, and really the sleepless nights have kind of kicked in. So I think there's a lot of stressors coming to bear at that particular point. So perhaps that's part of the context, but it does seem to be that early postpartum stage is the time of sort of highest prevalence.
And then I kind of also wonder about, the role of what's happening with the biology, but also, the non-birthing parent also is having changes in biology too. That's happening. The brain is changing immensely during pregnancy, postpartum, and then postpartum for the non-birth parent. And so, what is happening there that may be kind of setting off, trying to kind of, be protective, but like find the right level of protection for the family.
I mean, now you've sent me down this path that John probably doesn't want me to go down. But I was going to ask Fiona, well, how do you interpret these results? Why might it be the case that it's in this early part of the postpartum period, I guess middle, depending how you define postpartum? Actually, I'll pitch that first. Fiona, how did the paper interpret that result?
I think some of the things I've already mentioned, really. So, I mean, as any parent can relate, you're learning on the job at the time of sort of maximum vulnerability, of having to care for this vulnerable, wonderful bit of equipment, your cherished kind of baby at this time. So I think it's a very difficult task. As well as the sort of tectonic shift in the social landscape and all of the things which are happening around you too, partner relationships and so on. So there's a lot to kind of think about in terms of mechanisms. I mean, the paper didn't measure all of those things at that point, but I think that we could do more to understand a little bit why that's happening. But we know intrusive thoughts are very common. I think, Leckman's work sort of showing this primary parental preoccupation. It's very normal for all parents to be thinking so much about the safety of their child. But I guess in no other situation are you having to really operationalize that and keep the child safe. There's messages of danger coming, you might get it wrong, you might not sterilize properly, you haven't got the temperature of the room correct. You're suddenly in this kind of slight, making it sound awful, sort of nightmare of having to navigate all of that with very little sleep. So I think those things come to bear.
Yeah, you definitely didn't make it sound super fun. But it's a fun nightmare, And then, Mary, to your point, what are the sort of biological things? And then, John, we'll get to psychology. Don't worry. What are the sort of biological things that you're thinking about in this time frame that are changing for both the partner having the kid and the partner who's helping the partner have the kid?
Well, in becoming a parent, there are some interesting studies, and now, I mean, these are even from 10 years ago, but, looking at kind of the brain circuitry, the neurocircuitry patterns that are changing in parents and new parents. I'm not even considering postpartum OCD, perinatal OCD, but I think, those kind of connections between, like your amygdala and your prefrontal cortex and kind of these different, pathways that are kind of needing to be a little more connected to handle all the things Fiona just talked about. And then, I also, thinking about things like traumatic birth and just the things that have happened, I think the system, like your fight or flight system may have been engaged, and then it's sort of stuck on. And so that would, could lead to more of those intrusive thoughts or having a harder time letting go of intrusive thoughts. And then there's sort of the thinking about, is there, we know in postpartum depression, there is a subset of people who, and then kind of where is postpartum depression versus perinatal OCD? And we often called it sort of perinatal mood and anxiety, because we would have patients that would kind of have groups of they'd have their own unique group, but they would have groups of symptoms. And so in postpartum depression, there's some really beautiful studies looking at looking at actually even, giving people high levels of estrogen and then withdrawing that, and then seeing how that some people, there is this subset that are really sensitive to that withdrawal of the estrogen, and then that leads to increased depressive symptoms. So there is something happening there too. And I saw in the chat, things like postpartum thyroiditis. We've seen there's some really interesting stuff from like Verily Bergink's group looking at postpartum psychosis actually in thyroid. And so, I think there are all these changes that are happening within the immune system to make pregnancy happen, and in the kind of autonomic nervous system to deal with kind of the stress of what's happening. And then the kind of trying to find the right balance after going through pregnancy is a very strong physiological stressor. So, and the birth process.
I don't know if anyone wants to add anything.
Yeah, I'm recalling a study that was, I think it was from the Bard. It was about a decade ago. This one was written that looked at ACTH. Actually, no, sorry, I believe it was cortisol. But anyway, they looked at that in the 48 hours post birth, and then they found that actually those levels predicted harm-related obsessions 6 weeks later. So certainly we do know kind of that increased stress reactivity around birth seems to prime our nervous system to potentially have more intrusive thoughts down the track. So certainly there seems to be this biological component. Really interesting interplay.
And you have to be increasing cortisol throughout pregnancy. And the system is kind of, that balancing system has to have a different set point in pregnancy because there has to be these higher levels of cortisol to help with development. And so, you think about when someone's going into preterm labor, they often give them cortisol to help with the baby's lung development. And so there is kind of this, so then how that system rebalances, and it may be rebalancing to try to protect. Now I've had traumatic experiences in my life. This world is a place where I need to have a higher response to things and be more sensitive, or maybe kind of in the other, in PTSD, sometimes that system gets kind of burned out, that cortisol HPA axis system. And so kind of how those different people's systems are navigating all that.
John, you
I was
started.
gonna say there's probably some sort of evolutionary, benefit to all that, right? Having right up into having intrusive thoughts, right? And maybe not just for perinatal OCD, but OCD in general. It pays to have intrusive thoughts in a way, in a kind of a funny way. It pays to have intrusive thoughts about things that are important to you, right? You're more likely to protect the baby if you're having thoughts about the baby. And it's hard to test that out scientifically, but as far as a theory goes, there's probably some benefit to that.
Completely. Yeah. I tell parents all the time, like, that's your parent thought. And like, you're just really trying, you are like, sometimes your system's overdoing it for you, but you're really trying to protect you and your family.
I feel like this might be a stupid question, but so like, Mary, you threw out like a bunch of different biological factors to consider, and then Melissa followed it up with like, oh, there's this one study where like, you take this one nice little independent variable and then you look at this dependent variable. Is there a sense of like, when you look at kind of the massive changes that occur during pregnancy and after pregnancy, like what is kind of maybe the 1, 2, or 3 things that are most significant, or is that just kind of too hard to parse out at this point?
Oh, this is such a good question.
Good.
I've actually just been listening to some symposium on like trying to create clinical trials for probiotics, precision probiotics, and so like the microbiome, but really thinking about these things as systems. But then also, so I think, one of the key things that you have to think about is maybe what is your specific target? And like, can we look at, one component? Like, can we look at what, looking at the HPA axis, and maybe that is more those like kind of those obsessive thoughts, or maybe it is looking at the kind of the heart rate variability, which is like the beat to beat variation of the heart, and like how that reflects what's happening with the vagus nerve and the vagal activity. And maybe that is a specific target. Maybe that is specific. Maybe we have a kind of hypothesis that specific component is specific to one specific type of symptom.
Wow. Okay.
So try and kind of break it down into these, but also recognizing that it is this system, right? And so how do we kind of both look at a specific mechanism, but also have a systems approach where we recognize the rest of the system is impacting that specific, particularly if you're trying to move, and part of it is going back and forth. Can we go from simplified models to, larger clinical, medical record kind of data, and then go backwards, like kind of go back and forth between those two.
Mm-hmm. And then I imagine there's like a whole school of thought that like looks at something like perinatal OCD and thinks, oh, there's like a very psychology oriented way to approach explaining the cause of something like this. And I was wondering if anyone can give some meat on that bone.
I guess I have one thing to add to what Mary was saying in terms of biological factors that also relate to the psychological factors as well. And I apologize if you can hear my dog snoring in the background. I'll put myself on mute when I'm not talking, but there does seem to be some quite compelling evidence, not only with postpartum OCD symptoms, but also in the general OCD population as well, that sleep disturbance also plays a role. We know that kind of sleep disturbance in mid to late pregnancy as well, insomnia, predicts onset of symptoms in the postpartum period. There's some really compelling research that might be involved. The mechanism's not really unclear. Some researchers have thought, well, maybe there's an association between sleep disturbance and the postpartum, an increase in neuroinflammation in select brain regions, and maybe that being involved with OCD. But also there's a lot of psychological factors that could be involved. So when we look at kind of the OCD population in general, kind of outside of the perinatal period, what we see is the other factors like repetitive negative thinking, and also anxiety sensitivity, which is that tendency to, I guess, kind of catastrophize when we have those physiological cognitive symptoms of anxiety might play a role as well. And also things like confidence in memory. Maybe when we're sleep deprived, we're more likely to kind of doubt our memory, mistrust our memory, and kind of think, well, maybe I need to go back and check that again because I'm sleep deprived. I could have missed something really important here. So we seem to know now that sleep is maybe involved, but not so much the mechanisms just yet. It's a bit of a watch this space.
I'm a bit hesitant to explain John's work as he's actually here, but some very elegant and important work that you've done in terms of identifying beliefs and relevant to OCD that has, I think, really elucidated some of the mechanisms, particularly the beliefs about the importance of thoughts and responsibility, which we know are really important candidates for kind of how people then interpret intrusions. And I think, if I may say, John, you've demonstrated, I'll hand over to you to explain fully, but you've demonstrated that those beliefs can be measured antenatally and can then predict distress in the postnatal period. So certainly of relevance.
Yeah, we found that in a study about 20 years ago. And actually, Mary and I are part of a large study here in the States at 2 sites. And we're just starting to peek at the data. And we're actually finding that again, that when folks have these, they hold beliefs about their thoughts. Like, if I think about hurting the baby, that means I'm a bad person, or I'm going to lose control and do it. They overestimate the importance of their senseless, these kinds of thoughts that we all have. And that controlling for lots of other stuff, that seems to be a really good predictor of, after they have the baby, who's going to develop more severe symptoms. And to the point that somebody was asking about a prevention program. We even developed and tested, again, about maybe 10, 15 years ago, a prevention program where we found that when we identified folks that scored high, this is before they had the baby, during, kind of the second half of their pregnancy, and we only worked with the childbearing moms, they had these kinds of beliefs that thoughts are really important and overestimating threat and responsibility. When we gave them an intervention aimed at reducing those kinds of beliefs, cognitive behavior therapy, they had fewer OCD symptoms in the postpartum than did women who had a control condition where they just kind of learned about postpartum, mental disorders. So we've got some, again, it's not a perfect predictor. It accounts for not a huge amount of the variability, but I think that we've got some directions as far as intervention.
Yeah, Fiona, thanks for making John talk about that. That's not that's not a predictor I honestly would have expected. Like the extent to which you think about your thoughts, in a way. But I mean, the way you've described it makes sense. My initial intuition would that it'd be something to do with like I've been told over and over again that OCD is associated with a feeling of like increased responsibility, I guess. But I guess it could be responsibility over your own thoughts. And then when you have a kid, now you got this huge responsibility. So like, of course, the OCD might shoot up a little bit. I don't know if there's any evidence of something like that too, but that was just my hunch.
Yeah, these, again, they explain a portion of what's going on. I think a lot of the other, whether it's other psychological or biological factors, certainly play a role. I think, the factors that contribute to OCD, really to any mental disorder, are, just hopelessly complicated. And it's
Don't say hopelessly. Come on, I'm young.
Well, one day we'll figure them out, but it might be after we've all had our time on Earth. I hate to say.
And
Fine,
I think
I'll a little last hour. Yeah, Melissa.
Maybe not you, Kyle.
I think the wonderful thing about that body of work that John and your colleagues did earlier on about 20 years ago is that it's actually been replicated. It was kind of a validation of these cognitive behavioral models that we already had of OCD, and that study provided a wonderful set of studies, provided some wonderful validation of that. But then as well, it's been replicated in a number of other studies that have found a similar thing, that those thought fusion beliefs, so believing intrusive thoughts, maybe that means I'm mad, bad, or dangerous, and those interpretations of those intrusions are really important. So there's a lot that we don't know on the biological side, but what we do really know is that it really seems like these beliefs are a consistent predictor, and something that we can address through treatment and maybe prevention and psychoeducation, which is exciting.
I have found to that point, I've really found, for patients who were having very severe sort of intrusive thoughts to the point that it was paralyzing and they actually were, hospitalized, for them to be able to, there was relief in hearing both our thoughts are important and it's what makes us human and validating that, but also they are only thoughts. And so, and to some extent, that's also true with suicidal thoughts too, kind of helping people navigate some of those thoughts at times. And so I think there is this kind of, for intervention, it's really key, and patients appreciate that, and these are things that's why, treatments like CBT and exposure response therapy can be so helpful for patients. And
yeah, this is a good segue to talk about treatment, which is something that I always like to make sure we cover. And this is where I'm going to mention a little bit of the Pandora's box in my own head that Fiona opened. She sent over some papers about CBT for perinatal OCD, and there was something in the introduction where she mentioned that we haven't studied CBT with ERP with exposure specifically in this population, and that there may be some concern about the anxiety associated with exposure. So I want to ask, what is kind of the best way to treat perinatal OCD?
Well, should I pick up there? So, I mean, the papers I sent were about particularly treatment in pregnancy. And I think in my experience, that's where therapists have the most anxiety about delivering all sorts of treatment. And it's very interesting to kind of think about, implementation of CBT. So I think there's a general message that therapists can be a bit reluctant to do exposure anyway. So I think maybe sometimes we have our feelers out for reasons not to. But there's a specific concerns about, are we going to kind of somehow cause harm? And of course, it's really important for us to always think about any negative effects of the treatments that we deliver. But I think as a result, it's really a bit of a gap in the evidence base as to what can we do treatment in pregnancy, and how effective is it if we do our kind of normal treatments. So that was what my study was attempting to kind of really focus in on. And I sent you some of the qualitative results of that. So we know it worked pretty fine, and as you would hope and expect. But we asked the patients and the therapists what it was like to deliver that treatment in pregnancy. And there was quite an accord in terms of that experience. So, we can't be certain of any outcome of pregnancy, and we all have to accept that. And the patients really felt it was important that therapists were confident in delivering that and navigating that message. And that, that's the case with delivering our treatments at any time. We can't guarantee that nothing bad will happen, but that's the way, that's part of accepting life. And it's the same within pregnancy, and it can work really, really well. So that's my message and understanding from that treatment trial.
I love that about the uncertainty and really helping people navigate that part. And to Melissa's point earlier about, even then kind of the self-doubt part, thinking about those concepts and helping, how can we in pregnancy kind of help patients hold all those things, because I think the uncertainty is an important component, and there are, bad things, negative things can happen, and so we have to hold that and help people learn to hold that.
Yes, and it's not always easy, but it can just work so well. And I think there's always a case for, let's work on the anxiety now, and that will give you a better pregnancy, regardless of anything else. So that's what we always return to.
But do you think there is some anxiety that's good? And this is kind of what I have seen in some of my cohort was that, we have this increasing anxiety in the third trimester. And that's also kind of when inflammation is actually ramping up to get you ready to deliver. And so I've really struggled with this idea that, maybe some anxiety is helpful. And so how do we determine that,
For sure. And I guess that's where we started as well. What's normal and what's helpful and what's unavoidable. And I suppose it's always just trying to move the dial as to kind of, what would someone in your friend who's at the same stage of pregnancy, what would we expect? And I guess trying to work out what are we aiming for here? And I guess that's the same for treatment at other times. It's not that we want to eliminate all experiences of anxiety, but we want it to be useful, if we can say that.
So just to make sure that I got everything, is there kind of modifications to traditional treatment that you think ought to be made if someone's currently pregnant and they're asking for ERP, or does it seem safe to just proceed as normal?
It's a good question as to what's normal, because I guess it's always idiosyncratic and tailored to the person's goals. And in my experience in pregnancy, there are general things that you probably wouldn't do in the same way. So it's within the bandwidth of, I would say, what to do, compared with a pregnant person who doesn't have OCD. That's generally what we're kind of aiming for. So perhaps we'll save the really hardcore exposure for the postnatal bit.
I would agree with that completely. And back to what Mary was saying before, it's normal when you're pregnant, whether you have OCD or not, or any anxiety disorder. People are going to be stressed. It's one of the biggest stressors that people go through, in life, having a baby, and so you're gonna worry, you're gonna have anxiety about one thing or another, and probably if you're doing it right, the exposure therapy probably isn't creating much more anxiety than the person's having anyway if they have OCD or some other sort of anxiety disorder. But I think that, I guess there are there's certain foods you don't want to eat when you're pregnant, and, things like that are probably worth checking in with, official guidelines before you do exposure therapy to those things.
Yeah, I think you've highlighted the most important thing. We do the exposure not to kind of cause anxiety, but to help anxiety.
Yeah.
So it's really the evidence that people kind of actually usually improve very well with it. They've learned something new, and that's the point. And often in the doing it, it's not nearly as bad as the fear of doing it.
Yeah.
That's almost my universal experience.
That's
OCD
right.
kind of stops you trying.
To John's point, I was talking with my sister about this yesterday, and I was like, yeah, like I was reading this paper and kind of raised this interesting thing that like, oh, maybe there's a risk of doing an exposure because it's anxiety producing with a pregnant woman. And she was like, well, yeah, but isn't OCD anxiety producing? And I was like, yeah, that's a fair point. I also want to ask, like, if I'm someone who, let's say in my case, I have sisters, OCD runs my family. Is there something to do to help kind of ensure that I maybe can guard against OCD as I go through pregnancy and enter the postpartum period after pregnancy? If I know I might be, up for risk for something like this.
I came across this not too long ago. Someone is working on like a website to address exactly that. That's kind of like cognitive behavior therapy light that you would do. You go online and you do some educational stuff, and you learn, some information about everyone has intrusive thoughts. That's not the problem. The problem is how you interpret them. Let's look at some healthy ways to interpret these thoughts. You should expect to have them. I feel like I came across someone who was working on, developing a do-it-yourself program, like a prevention program. I can't remember where.
You guys know?
Yeah, I mean, that sounds super sensible. And sometimes, we work with people who are then in a subsequent pregnancy and they've had such a horrible time. They're going, how can I avoid relapse? We're having these similar conversations. Like, well, we know how, we now know under the bonnet how OCD works. It's not going to surprise you in that same way. What might come up, really getting people to kind of think through that. And what would you do? Is the OCD going to tell you just to keep Googling all of the ingredients to everything that you eat? And it's like, probably that would be the sort of thing to do less of. I don't know. So there's lots that we can do to kind of be forewarned and forearmed to try and help with that.
Hey, to that end, back at 1213, HG asked a really great question. Are there any initiatives toward educating providers, midwives, doulas regarding perinatal OCD, screening tools, things like that? And we're working on it. There is a worldwide, I know Melissa's part of it, there's a worldwide, and so is Mary actually, a worldwide group of folks that are trying to make folks more aware. It's going through the International OCD Foundation that are helping to make providers more aware of perinatal OCD, because depression gets all the press, psychosis and all of that, and general anxiety. A grant has been submitted for funding through the IOCDF. Fingers crossed that we get that so that we can study that even more. We've developed, actually, Mary and I, part of the study that we've been working on the past 5 years. We were actually passing a manuscript back and forth. Mary and I were just taking a look at it earlier this week. We have a 4-item measure. So it's very short, and doctors can use this in busy medical settings. It could go into an EMR, perhaps, a screening questionnaire that folks can very quickly, identify if they're experiencing OCD symptoms in the perinatal period. And those 4 questions seem to be pretty good at distinguishing between who has OCD and who doesn't. And hopefully,
wow, just 4 questions?
4 questions. There's going to be a presentation on it at the OCD Foundation conference in a couple weeks in Orlando. If you're interested, stop by our poster.
And what I love about that is we think about, we're finally getting, postpartum depression I'm so glad, has gotten a lot of discussion around it, and people, increasingly more aware. And so, we have, and actually just 10 years ago, we did not actually have recommendations that there should be screening for depression in pregnancy and postpartum. And then they came out and said, yes, we actually should. And, part of the question is always, well, it's not just the screening. Like, it's not just giving someone a piece of paper. It's about a conversation, and it's about how do we then have the resources for people when they answer yes to questions or. But all of our screening tools, like the EPDS, doesn't get at intrusive thoughts. And so we've really made an effort with the statewide consultation lines in the US that, really started with kind of a focus on postpartum depression, but now are really branching out to try to educate anyone who, in North Carolina, NC Matters really makes an effort to educate anyone who comes in contact and provides care in different ways to pregnant and postpartum people, to really be having these conversations about, did you have any thoughts about harm to the baby? A lot of people have thoughts about harm to the baby. Did you have any thoughts? Let's talk about it. But I think having kind of something like those 4 questions is a nice sort of bridge, like a nice starting point for people to really get them remembering, oh yeah, I need to have that conversation.
And we have to be very careful about how we educate folks about this, because as you mentioned, it's easy to confuse, like, do you have thoughts about harming your baby? And it's easy to confuse that with psychosis, which is a dangerous thing where people do sometimes actually harm their baby. There was the famous case, Andrea Yates, again, like 25 years ago, who drowned her kids in the bathtub. She had postpartum psychosis. But we saw people in our OCD clinic. I'm the next Andrea Yates, because sometimes now I have thoughts about doing that. When my wife and I were going through birthing classes for our first kid, it was right around Andrea Yates time. And the teacher said, now, you might have postpartum depression, but if you have thoughts about harming the baby, you have postpartum psychosis and you need serious, help for that. And we were doing our research then about, like, no, everyone has intrusive thoughts and all this stuff. I raised my hand, and I don't think the teacher liked that very much, but hopefully things have changed since then. But we need to be careful the way that we educate folks and normalize this experience of intrusive thoughts, and help people to be able to talk about that more, so that we can, identify them and give them what they need.
And when I talk about that, it's a really good point. I really want people to be able to kind of hold all those things, like hold what is the experience of the patient, and not just have it be a reaction. Because I have had patients who had intrusive thoughts, and then they were referred for child protective services, and that just adds to their OCD thoughts that they have psychosis and that they are going to harm the baby. But then also I've had patients where, postpartum psychosis is a complex thing that is not well defined. And is a spectrum. And so I will have patients that will kind of, have these intrusive thoughts that at one time are intrusive, and other times they're not sure what to do with them, and they're confused by them, or they are thinking that they should act on them. And so, it's really important to be able to hold help providers be able to just sit with people and figure out, try not to put on them what their thoughts are, but really have a discussion about a conversation, and not expect everyone to have the conversation, but how do we then refer people to people who can have a more nuanced conversation about, you're having these thoughts. What do those thoughts mean to you? And let's understand your experience and how we help you, and have a healthy and happy, period.
And we should probably say that, a lot of folks with OCD, when they have intrusive thoughts about harm, they worry about, what if I have psychosis instead? I'm going to do something, and they spend a lot of time ritualizing, trying to figure that out. We should say that postpartum psychosis in general, is extremely rare. And so more likely, I don't mean to give folks reassurance, but I guess a little bit more than likely, if you have, way more than likely, like not 50-50, but like way more than likely, if you have intrusive thoughts about, harming your baby or something like that, and you're fighting them and you're doing rituals around them, it's a really good bet that is OCD, and that's what you want to look for help with.
Yeah, but it does seem like you give this kind of screener, and it's really, to some extent, the onus is on the healthcare provider to sit down, like you were saying, Mary, and not just look at the screen and not just like these 4 questions and dig a little bit deeper, but the screener is a super good way to kind of get that conversation started and get the ball rolling. We don't have too much time, but I like to do this thing, and I think last time I ran out of time too. But I'm gonna try to force you guys to do it anyways. Fiona, if you have like kind of something you'd want the audience to take away from the stream, because there's been a lot said, but if there's something you want someone who's thinking about perinatal OCD, and we have a very diverse audience, then they could be clinicians or patients or whatever. But what's one thing you'd like someone to take away who watches this stream?
I always think the thing to take away is hope. It's really, really treatable. I've had many, many patients do so well with treatment, and there's always an awesome parent underneath there. And OCD has just taken things in a particular direction, but yeah, there's so many good things that can be harnessed.
Hope's always a good thing to end on. Melissa, do you have any sort of final thing you'd want someone to take away?
I think one thing that I see people with OCD, they often come in to practice, or and they're concerned about, well, I have had OCD in the past, or I'm on top of my OCD at the moment, but what happens if I decide to have a baby in the future, or what's going to happen to my OCD in the postpartum? And they really might worry about that. And I think what we've learnt, I think from the research, is actually, based on what we know so far from the literature on treatment, is the things that help with OCD, ERP, CBT, SSRI medications, medication options, also seem to work really well for OCD in the perinatal period. So with some modifications sometimes, but it's helpful. So I think it's really important to keep that in mind. There are some differences in terms of how OCD might present in this period, but also there's lots and lots of similarities. So there's lots we can draw on in terms of treatment.
Awesome. And super duper quick, Mary, same question to you.
Yeah, I love both what Melissa and Fiona said, and I would just add that I'm really excited that you had this conversation today, and that I think it is all about conversations and talking about these things, and just continuing to get this out there so people feel like they can talk about their thoughts, and that we can sit with people in thinking about their thoughts, and that there is hope. I think this creates hope for me, that we, and also that to keep supporting, kind of looking at the mechanisms too, because that will help too.
Well, I learned a lot this stream for sure. It flew by. From my perspective, I hope it did for you guys. Thanks everyone for tuning in.
Great show, guys. Yeah.
It was fun. Yeah. I want to make one announcement. We have the 29th annual conference is in Orlando. As a native Floridian, that makes me happy. But it's an amazing opportunity though to meet people like John. Actually, I think all the panelists we said are coming to the conference. Fiona, I don't think you're there for that. I don't know if you are. No, unfortunately, you can't meet Fiona. But John, Melissa, and Mary will be there, and I'll be there. And it's just a great opportunity to connect with the whole community. And you can register for the conference at iocdf.org/OCDcon. I'd love to see you there.
Yeah, if you're someone who watches the live stream and you see me walking around, please come up and say hi. It'd be great to meet you.
Yeah, same here. All right, well, thanks to all the panelists. Thanks to everyone watching, and we'll see you next month.
Thanks, everybody.